Good afternoon, good evening, good morning, everybody, wherever you are. I would like to welcome you all to this session in the refractive session number 2, keratorefractive surgery, today, Friday, in this Middle East ophthalmology meeting. I'd like to welcome my co-moderators and panelists. I'd like to welcome all audiences, all the people who allocated their time to attend this important meeting. Please feel free to ask any question during the presentations by raising hands, by chatting as well. And we will try our best to answer your questions. And we will start very sharp at 5:15 with the first presentation. So the first presentation will be presented by Dr. Safwan Al-Bayati. It is about customized laser vision correction. Please, Dr. Safwan, the mic is with you.
Okay, thank you, Dr. Mazen. And I'd like to thank Dr. Muhammad Al-Amri to give me this opportunity to present this subject or this controversy subject in this session. Good afternoon, everyone. Good afternoon for the panelists, and good afternoon for the all audience and speakers. This presentation regarding the things that all of us would like to do it, but in a safe way, the customized laser vision correction. I don't have any financial closure for any product will be presented here, unfortunately. And this is my reference, and this is the objective.
And, share, just a second. Share your screen, Dr. Safwan.
I'm sharing. It's shared. It's already shared.
We cannot see it.
We cannot see your screen, Safwan.
Okay. Done. I will do it again. Now share again.
Yes. Now we can see.
Okay. Done. So, just 1 minute, please. So that's that subject that we all need to do it, but in a safe way. So using the wavefront, ocular, or corneal to drive excimer laser ablation was one held as achieving extremely good visual acuity. Some studies shows that high proportion of patients. I'm just having difficulties to. Patient achieving very good unaided vision, while others showed that amount of induced corneal abrasion was lower with the wavefront guided treatment compared to the standard ablation. Several factors limit the potential effectiveness of such treatment in providing better outcome than standard ablation. Difficulties with a cyclotorsional registration and tracking, because we need track system, especially with the older laser platform. Issue and tissue and assumptions with the translating ocular wavefront measurement into corneal ablation pattern and postoperative corneal surface remodeling limit the theoretical effectiveness of any customized approach. Nevertheless, wavefront guided technique have shown promise for improving outcome in highly ablated unoperated eye and for enhancement after refractive surgery. Topographic guided treatment have also been available, and there is an ongoing debate as to which is the better platform to perform these procedures. Now, wavefront guided ablation tend to remove more tissue. Here, when I'm saying wavefront, I mean a wavefront as an ocular and corneal. That's what I put it in the beginning. So I mean both. More tissue to achieve the same refractive changes than the refractive or abrasion-free. So hyperopic overcorrection in wavefront guided myopic refractive surgery can be explained by the interaction between positive sphere abrasion and the defocus, the low order abrasion. What's the type that we have in customized ablation? We have, as I said, corneal wavefront and ocular wavefront. I will run in a way that we will reach the the target. Topographic guided customized ablation, the TCAT, or what we call corneal wavefront, the hallmark of topographic guided customized ablation is that it's designed to address corneal tissue exclusively, with an emphasis on smoothing or normalizing the anterior corneal surface. It's often used to treat low-order abrasions such as myopia, hyperopia, and astigmatism, with the corneal high-order abrasions such as corneal scar and such as in corneal scar and keratoconic. Now, this ablation profile uses corneal wavefront, corneal high-order abrasion that can be derived from a corneal topography. The elevation map is incorporated into Zernix 7th order using tomography corneal map, getting the K reading, central corneal astigmatism, geometric central or pupillary center, and the pachymetry from the corneal map. The existing and the induced high-order abrasions will be treated in this profile. Sorry that I'm quick, just to reach the time and saving the time. The ocular wavefront dependent refractive surgery aim to make the eye optically perfect. The ability of spectacles, contact lens, intraocular lenses, and diffractive surgery to eliminate only the sphere cylinder refractive error of the eye without reducing the higher order abrasions make these correction less than ideal and inspired the use of wavefront ablation. Wavefront guided ablation, correcting the abrasion based on an integrated diagnostic unit composed of elevation, topography, and wavefront analysis. Why topographic guided? Topographic analysis can measure up to 8.5 millimeter of corneal diameter. Topographic map is not limited to pupil size and measure a much larger amount, 6,000 point compared to 1,452. Now it's improved. Now there is a machine that improving it's reach about 1,600 point in ocular wavefront, which render much more accurate information on the corneal irregularity, and it's not affected by patient accommodation. Topographic map can be obtained almost in any case of corneal irregularity, even in highly abraded cornea. So why not ocular wavefront? Now here there is one point that we need to add it to the topography. The old topographic machines, it wasn't able to assess the total corneal power. But now, with the use of the new machines like MS-39, now we are able to assess the total corneal power. Means that the total corneal high-order abrasions, including the posterior. And those machines having the ability to measure the posterior high-order abrasions and anterior, and both of them. And that was excluded only for the ocular wavefront. But now in the new machines, we have it. Now the second step that we are waiting is that to apply this information from the topographic high-order abrasions to apply it on our laser platform. Now, why not ocular wavefront? For example, for me, ocular wavefront analysis has some limitation in analyzing and correcting irregular cornea. It measures anterior corneal surface only, but it gives the total ocular, including the posterior. It has no ability to measure the posterior corneal surface alone. It measures it as an ocular. So total ocular wavefronts include the axial, the posterior corneal surface, anterior and posterior. To select posterior only, we need a placido disc added to the ocular wavefront. So someone would say, no, we have it. Exactly, you have it because your machine having a placido disc adding to the ocular wavefront in a way that you can select. So placido disc, it will act to show the high order abrasions of the anterior and posterior, and the ocular will show the total. But in total, we can treat the total corneal power when we have this ability. Most wavefront sensors cannot measure highly aberrated cornea ocular wavefront analysis is restricted to pupil size and affected by patient accommodation. Most ocular wavefront sensor limit the analysis to 1 millimeter inside the pupil diameter, which limit the results knowledge of the corneal irregularity. Now, advances in corneal wavefront, as I mentioned it, so we can skip also this one. Now, here it's very simple ablation profile that shows what's the difference between, on the left, you can see the abrasion free, and on the right, we can see the corneal wavefront guided for the same patient, how the profile totally is different. Now, to summarize our optimization, what we need to do, if we are not changing the central ablation depth of customized ablation compared to the ablation depth of abrasion-free, we will end up with overcorrection. That's very clear. If the central ablation depth of the customized equal to the central ablation depth of abrasion-free, we will end up with undercorrection from 0.5 to 1 diopter. This equal to around 6 to 12 micron tissue ablation or tissue consumption. That's because there is an interaction between positive and negative spherical abrasion. Or we can translate it in other way. If we are treating spherical abrasion, we are just like treating a positive, a hyperopic ablation. So we are inducing more myopia. So that's, anyone imagine that we are treating spherical abrasion and trefoil. Here, those two, it can create more myopia. So if we will keep the consumption of tissue of abrasion-free, that we need to measure it as a standard for any customized treatment for the same patient. If we need to keep the ablation depth, central and peripheral, exactly the same as the abrasion-free, we will end up with undercorrection because of the effect of the biomechanic, corneal biomechanics to the treatment of the spherical abrasion. To prevent overcorrection post-customized ablation, the planned central ablation depth should not be significantly greater than that of the abrasion-free for the same refractive error and optical zone. So each optical zone has some difference than the others. But the question here, what's the difference should be? 4 microns in favor of abrasion, customized ablation, or 5 or 6 or 7 or 10 microns? And in which optical zone? That's what we will see it in this study or in this presentation. Sorry. In case the difference between central and peripheral was more than 5 microns, then we need to adjust. We need we need to adjust the central depth to be within the 5 micron. Otherwise, those that they have difference more than, let us say, for example, personally, for me, more than 10 micron between the central and peripheral, after the studying the customized ablation, those patients, they are not candidate for same session ablation or same session treatment, because if the difference between central and peripheral exceeding the 10, then 100% we will end up with a refractive residual in hyper or in myopia. Now, different machine, different protocol, all aim to reduce the post-operative surprises, but still we have over and under correction, unfortunately. So how we can try to overcome it? First protocol, I will start with the Schwinn-Tamaris protocol tools. We can see in Schwinn-Tamaris, we have a software that it can adjust the low order abrasion just to save tissue. And here, this is the example. For example, this patient, we adjusted and I used the default and the constraint. You can see in the second row, there is a constraint, and this constraint shows the ability of this machine to adjust the sphere and cylinder and axis. And there is a default. This is the default that machine giving, or the surgeon can change this default, changing the sphere and changing the cylinder according to the decision of the surgeon to change the low order abrasion, which is mean the sphere and cylinder. Now, that's the surgeon I decide to change this constraint, not to use the default. So I use 0.25 for sphere and 0.25 for cylinder, and then I end up with a change in the consumption. If you will go to the right side, the column, you will see that the upper one, the current, which is 149 micron, and then it reduced after the trials of the machine to 146. Then Schwint also having ability to select the high order abrasions according to the clinically significance. So here is the total, and here after the selection. And this selection can be manually or can be by the machine customization process. So you can go through depth, minimizing the depth in case of myopia, or minimizing the volume in case of hyperopia. Now, the third, which is more important issues, the machine will give us the high order refraction. Like, for example, if you will go to the right side, the third column, you will see that high order refraction means that the high orders that we have, it gives you the refractive equivalent in diopter. Like, for example, in this case, you have plus 0.82 diopter for sphere and minus 0.19 diopter for cylinder. So you can deduct it from your low order, and you will end up with what? You will end up with the same consumption, unfortunately. That's what I said. Still, even with these tools, we need to manipulate. We need to manipulate in a way that the consumptions will be around according to the optical zone. Like, for example, here I'm using 7 millimeter. So here I need to make the difference between them 6 microns. And I will show you exactly this patient here. We will see this was the refraction of the patient. This is how we will apply the low order abrasion. So if you go to the left side, the first row, you will see that the sphere was minus 4.5 and the cylinder was minus 0.25 on 150. And then after manipulation, this is the case in general. The gender, she was a female, age 23, and the right eye, the femtoLASIK, 7 millimeter optical zones, that's very important. The comma was 0.2. Its refraction was 0.19, trefoil, same. And spherical abrasion was 0.34, 0.2 diopter. High order abrasion refraction was plus 0.82. The preoperative refraction was minus 4.5. We suggest, our suggestion, according to the difference of 6 micron here, because the optical zone was 7, it was minus 4.35. Now, if anyone go through the classical way to deduct the plus 0.82 from the current refraction from minus 4.5, he will end up with a 3.75. The patient will end up with undercorrection. When we did our manipulation for the lower order abrasions, according to the difference of 6 micron, patient end up with plus minus 0.25, and post-op vision was 1. Now,
Dr. Safwan, 2 minutes.
Well, I will try because still I have two slide. So just give me and permit me for that. Inclusion criteria.
2 minutes. Okay.
Select the best measurement if we can. The important issue is that CDVA for those patients is lower than 1, and the higher order patients is more than 0.5. That's why we are selecting them. We are not getting patients that have CDVA is 1 and any higher order abrasions below 0.5. Now, that's one of the cases, post-refractive, and has a higher order abrasions of 0.889. And that's the important tables that I need to show, that in each optical zone we have a difference between the high order abrasions and the abrasion free. In 6 millimeter, for example, we need to keep 2, while in 8 millimeter, we need to keep 10. And if we will go to the case presentation, that's the first case presentation, and we can see accordingly the refraction for the patient was minus 3.5, minus 1, and we end up after the treatment with a residual of less than 0.3. And that's the same case. Now, with the abrasion, the refractive that we entered is minus 1.65, minus 1.25 instead of minus 3, minus 2. To keep the difference, if you will go to the consumptions, you will see that with the abrasion is 148 for the central, and with the abrasion free, what was 142. And we end up with this refraction at the end, minus 3, minus 2, to minus 0.5 in first month, minus 0.5 3 months, and minus 0.25 at the end. Now, the second protocol is 1 minute for that's Alcon Contura. Now, what they put for the Alcon Contura, they are considered that the surgeon will go through and follow this protocol. This protocol, unfortunately, I don't have time to show it in details, but one example of it, that if the refraction cylinder, that's what it's given to the surgeon. The refraction cylinder, if it is more than measured the topographic cylinder, enter the measured cylinder, we will use the topographic cylinder, and the difference will be divided by 2 and added to the sphere. Now, when we measure this, when we did, for example, minus 3, that's the sphere, minus 1.5, that's the measured.
Try to conclude, Dr. Safwan, please.
I need only 1 minute, Dr. Mazen.
Okay, 1 minute.
Minus 3, and the cylinder was minus 1.5, while the difference between the both cylinder, the measured cylinder was minus 3, and the topographic was minus 1.5. The difference was 0.75. Here we need to add the 0.75 to the current refraction, the current sphere, so it will be around 3.25 on 1.5, axis 20. But when we measured the consumption of the tissue, where the patient having the primary refraction before the manipulation, we found that after manipulation, still we have consumptions more than the 6 micron or 7 micron. So we need to adjust. That's why some of the patients that they have contura, they are ending with the hyperopic shift, and that's the cause. Great, thanks for everyone. I'm very sorry for late.
Thank you, Dr. Safwan. So to conclude, your message is, in your way, you are trying to approximate the ablation depth of the aberration free to avoid any extra consumption of tissue, to avoid overcorrection and undercorrection. And this is done by manipulating the central ablation depth to be within 5 microns from the aberration.
6 to 7 microns around, yes.
Okay, that's fantastic. Thank you very much, Dr. Safwan. Would you please stop sharing your screen?
Yes,
and
I will
I'll
give to stop my sharing.
Yeah,
so,
thank you. Now we will go to, for the sake of time, we will ask Dr. Sandeep Mitra, please, to give his talk about advances in lenticular extraction. Dr. Sandeep, please.
Yeah, thank you very much. Is it now visible, my screen?
Not yet.
You are visible now.
Sorry. 1 minute. Is it visible now?
Yes. Yes, we can see.
Okay. All right. Fine.
Go on.
All right. So basically, lenticular advances in lenticular extraction. First of all, sorry. Good evening, everybody. Thank you very much for this great meeting. My experience with lenticular extraction really dates back to 2012 when Carl Zeiss launched the first machine to do Relax Smile procedure. I have no financial interest in any of the products discussed here. The main objective of this talk today is, what is the established lenticular extraction techniques, Relax Smile and Flex? What are the challenges with present technique and its limitations? The present advances in these techniques, newer generation of lenticular extractions. These are the aims. So what is the physics behind the process of lenticular extraction, especially flex and smile, which was started by Visomax machine, which is a femtolaser machine. It's a 500 kilohertz femtolaser machine. The infrared spectrum produces 150 nanojoule of energy. It causes photo disruption with a small bubble, and these are about 1 micron spot placed about 2 micron apart in a spiral pattern, and then these are joined together to make a cut. The centration is used by a green blinking light with 3 concave glasses, which are called the treatment cups. They are in 3 sizes, small, medium, and large. And the suction is applied at the limbus, which maintains the stability of the treatment process. The posterior surface is cut first, which is called the lenticular cut. And then the anterior surface is cut, which is called the cap. And the difference is about 1 millimeter. And a blunt spatula is used to break these tissue bridges between the bubbles to achieve a regular cut. The most important point in my practice is the head tilt, which is required to circumvent the docking of the cup over the eye. And it's very important because if you are not in the proper visual axis, then you don't get a proper lenticular cut. Pre-op marking by a topographic image is one of the techniques which I follow. Is that you, based on the Purkinje's image, you can mark the visual axis preoperatively on the slit lamp, and then you can use that as the visual axis. However, one of the other recommendations, you can ask the patient to look straight and do a soft docking before you do a hard docking. So that will allow the patient to look straight on the green light and allow you to center the image better. Whether you should go to the pupil center or corneal vertex center is a matter of discussion. But if you have an angle kappa, which is very large, which happens in hyperopic patients, of course, smile is not a good choice in these patients. For myopes, it really doesn't matter. You can go for either pupil center or corneal vertex center. The next thing is removing excessive fluid. Again, this is a challenge because if there is excessive fluid, there is a frequent loss of suction, and that is a problem to recut the lenticular. And you may land up cutting the lenticule in a different plane or a different set of diameter. The other problem is if you are not cleaning the corneal surface, you have meibomian deposits, you can have a lot of black spaces, and this results in very poor lenticular separation, and you might get irregular interface between the lenticule and the cap. The lenticular fragments, this is a common problem, and it can happen to anybody, especially in lower myopes. When you're correcting myopia of minus 0.5 or 0.75, the lenticular thickness is very thin, and then you might land up having lenticular fragments. So to avoid that, it's better to start doing smile with higher numbers, like for example, -5 or -6. Then as you get practice, you can go down to lower powers. It's also important that when you are doing these type of small powers, you can use a newer concept which is called hydroexpression. So instead of pulling the lenticule out, you can use a jet of balanced salt solution, and the lenticular fragments are expressed out. Or you can do a new technique called lenticular rhexis. The same way you do a capsulorhexis. This is also a technique which produces less trauma to the stroma, and the plane is maintained more sharp, and you get a better post-op refraction day 1 after the procedure. Keratoconus after smile, nothing is immune to keratoconus. So there was a concept that smile, although it protects, it gives a higher resistance because you are going less than more than 120 micron depth into the stroma. But remember, even in keratoconus, even in smile, you can have keratoconus. So you must not do any refractive procedure, at least not smile in a keratoconus or keratoconus suspect patient. And this is the Randleman's risk scoring system, and I'm following this for all my patients. Vacuum loss is was a major issue, especially if you're going to use a medium-sized cup or a large cup. These are required when you have very large pupils. So if you have a pupil size of 7 millimeter or 7.5, and then you have to use a lenticule which is large, or you're doing a cut in a very large pupil size, you might have vacuum loss. This can be prevented by avoiding poor docking, avoiding fluid accumulation in the passage under the suction cup. And if you are a beginner, it's better to go for a small treatment cup. Also, patients who are uncooperative and apprehensive, it's a challenge to do these procedures because they might move during the treatment and you might get double cuts. So you might cut once and then you have a second cut, and this might give rise to astigmatic errors. The other issue is decentration. Now, decentration is used to happen because you are poor docking. And if you have a decentered docking, it's better not to proceed with the SMILE procedure. Just go back and redock. That is the better thing to do. There are newer techniques by which you can recenter after docking. I'll come to that later on. Now, these are a few modifications and advances which has happened to the SMILE technique, and this has happened because of the new innovations, the newer generations. For example, the Zimmer, which has come up with the newer techniques. So you can actually do docking, and then you can recenter your lenticule based on a control, which is on the side. You can move the control and recenter the lenticule over the pupillary axis or the visual axis or the center of the cornea. So it is very good if you have a patient who have docked and then you don't know where the docking happens. You can always choose by manipulating on the software. The adjustment options are 1 or 2. Incision also is another advance which has happened, and this is especially for doctors who are either left-handed or right-handed. Of course, this option is also available with Visomax. The other thing is low energy concept. Now, with the advances, what we have seen is if you are using higher energy, you get a very rough cut. So because of the bombardment of the laser, so lower the energy. In fact, we use 26 to 28 millijoules, and these are lower energy. The newer Zimmer head actually has a lower contact from the eye. The working distance is less, and the cone is large. So the spot size is smaller, and they use very low energy to drive. So when the energy is driven into the cornea, the spots are tiny and they are separated by a very small zone. It gives out much more smoother cut. So this is an advancement from the Visomax, which is there. I'm sure they are also going to use the same technique in their future developments. The future challenges, one of the problem with SMILE procedure is to correct hyperopia. And it's the challenge because the shape of the lenticule is the challenge, and it actually undercorrects because of the shape, how the lenticule is designed. So this is one of the issues, and the regression is very fast. Within 6 months, the effect disappeared. So that's the reason why we have not been able to market the correction of hyperopia with the Zeiss. Of course, the evolution is going on, and we have to wait and watch and see what's going to happen in future. The presbyopic correction is not possible for the time being. The Presbyon software is mainly for femto-LASIK. Monovision with SMILE does not give good result in my hand, so I really don't do presbyopic treatment with SMILE. It's better to keep it for femto-LASIK patients. The other thing is lens extraction cannot be done for high order aberrations, so I will leave it to Dr. Safwan to try all these cases and refer it to him, and not try any SMILE procedure for irregular astigmatism. Dr. Ganesh et al. Had actually tried a technique called adding donor stroma to treat hyperopia, astigmatism, and presbyopia, and it is a technique which has been started, wherein a donor lenticule is fashioned and inserted into the cornea to correct hyperopia and astigmatism, and his results are very encouraging, and we need to see how this treatment pans out, and especially for keratoconus patients wherein we are adding tissue into the cornea and correcting the corneal thickness, and if not keratoconus. Preventing vacuum loss, I just told you about it. If you just use a smaller treatment pack or you reduce the suction time to less than 30 seconds, proper docking and head alignment, and if there is vacuum loss, it is better to use either the repair mode or reschedule the patients for a different time. The other challenge with SMILE is astigmatism, and we have seen that any astigmatism more than 4 diopters, there is always undercorrection. The problem is there are 2 types of torsions which we get when the patient is on the OT table. One is called the static torsion. That happens when a person moves from a sitting position for a lying position. There is a cyclotorsion, and then there is a dynamic torsion when the treatment cup comes and docks into the cornea. So one of the techniques is by marking the cornea at 3 and 9 o'clock and at the 6 o'clock. This is to use the mark, and then you can adjust the treatment cup once the treatment cup docks into the eye. The only thing here is that you must see that the marks are used by a pen which is transparent to laser, and the best way of looking into that is when you have the infrared camera on, you will not see the laser marks. So that's how it says that they are transparent to the laser beam. There is a study by Ganesh et al. which said that if you have used this technique of marker, then probably you get a better result. These are my references, and there are many references. So the talk today, actually, I am trying to summarize the techniques which I faced problem when I started my SMILE procedure way back in 2013. And along the line, I've been doing SMILE, and the problems I face, and I would ask the scientific community to come up with these solutions so that we gets more precise and we are able to correct not only hyperopia, astigmatism, also better lenticular extraction. Thank you.
Thank you very much, Dr. Sandeep, for being perfectly on time. That's great. Now, I'd like to invite Dr. Eileen Koch-Akbey to present her presentation, Refractive and Superficial Corneal Opacities. Please, Dr. Eileen.
Did I stop sharing my slides? Is it okay now?
1 minute, please. Do you hear my voice?
Yes, we do.
Okay. Hello?
Hello. Yeah, we can see your screen. Please go on.
Okay, I'm talking about refractive surgery in superficial corneal opacities. I'm from World Eye Hospital from Istanbul, Turkey. Irregular astigmatism is usually caused by irregularities of corneal shape and resulting factors as keratoconus, refractive surgery, LASIK flap complication, and radial keratotomy ring surgery, and penetrant keratoplasty and scars following the traumatic injury, and also some corneal problem caused corneal scar and irregularities, corneal degeneration, dystrophy, recurrent corneal erosion, and inflammatory disease. Okay, and irregularities decrease the patient best corrected visual acuity and cause irregular astigmatism and cause contrast sensitivity loss and cause optical aberration. And for the treatment, the reason of the superficial is corneal opacity is very important. And irregular astigmatism can be diagnosed clinically by corneal topography and wavefront analysis. And optic coherence tomography can be used to image the superficial corneal opacity, size, and depth. And also, level visual acuity can be checked with the rigid gas permeable contact lens. And after that, we're planning the treatment. We can do the PTK phototherapeutic keratotomy conventional and also or topo-guided PTK or wavefront guided phototherapeutic keratotomy. Or first of all, we decided topo-guided PTK, and 6 months later, wavefront guided PTK. I talk about one case report. We treatment a highly irregular astigmatism due to radial keratotomy, and in the right eye, first manifest refraction value 2.75, uncorrected visual acuity 0.1, and after the treatment,
Dr. Eileen, we are not hearing you well.
the irregularities and the treatment planning. And the other one is the left eye, the same patients. In the left eye, we have astigmatism, and after
Dr. Eileen, your net
is increased.
We have a problem with your net, please.
Sorry?
We have a problem with your voice. We are not hearing your voice.
Dr. Eileen, it
Voice.
seems that the internet
is okay?
unstable. Yeah, we can hear you now, but the internet seems unstable.
Yeah.
Oh, okay.
Go
I
on,
would
go on, no
recommend to
problem.
switch off the video.
No, we can see your slides. No worries. You can go on, please.
Okay. Sorry. The other case report, 21 years old female, and manifest refraction value in the right eye 8 and the left eye 6.75. And during the operation, it was accessed a flap complication in the left eye. And you see the pre-op left eye value in the ORB scans, and the regular astigmatism and the corneal thickness is okay for this number. And also we take eye design, and eye design we have to take like these patients because we provide personalized treatment with excellent results. And post-op pentagram, you see this like this irregularities upper side, and the correction the value is 4.50, and also you have astigmatism. She have astigmatism. And ORB scan post-operative, and manifest refraction value 1 and best correct visual acuity 0.4.
Dr. Mazen, we are not hearing Dr. Eileen.
Suited for disorder in the anterior between 10 and 20% of the corneal stroma, and because of that, we planned the topo-guided therapeutic keratotomy, and is to create more physiologic surface, and we excimer laser was and ablation depth was 50 micron, and useful successful outcome depends on the purpose selection is systemic disease or not. For example, diabetes, collagen, vascular diseases, rheumatoid arthritis, and systemic lupus erythematosus may have delayed epithelial healing and representing a problem for this therapeutic approach. Because of the systemic disease is very important, and visual improvement after PTK may due to reduction on the scar density because of the type of the scar and place of the scar is important, and also contact lens stimulation we have to in our clinic. And we take corneal topography and corneal optic coherence tomography because of with the coherence tomography used measure the depth of the opacities in the cornea, and also amount of the vision increase with the contact lens. And topo-guided treatment, you can see. One more again, I want to show the irregularities in the pentagram, and you see the 4.50 and the post-operative topo-guided PTK, the irregularities decrease, and the spheric equivalent values 2.75 and cylindric 2 in our patients, and the best corrected visual acuity is increased. And difference map you can see. And the pre-op scan, one more again, you see the irregularities and post-op, and post-op topo-guided, you see the wave-light, and we do the wavefront guided and after the post-operative wavefront guided PTK, and you see the difference map. And the pictures of the irregularities on the cornea before the wavefront topo-guide PTK and the post-op, and pre-op wavefront and post-op wavefront, you can see this difference between the numbers, and the visual acuity increases in our patients 35 days later, and 45 later you see the differences. And also op scans pictures. And before the surgery, we have the proper planning and which test patients needs, topo or wavefront, and sometimes these two methods can be combined. And on revision treatment, the thickness of the cornea and other parameters should be considered as in the first surgery. Thank you very much. Okay.
Thank you very much, Dr. Eileen. That's perfect. Now we have sufficient time, actually. And before we start the next presentation, I think we have 5 minutes. If anybody would like to ask any question to Dr. Safwan, Dr. Sandeep, Dr. Eileen. Let's start with the presentation of Dr. Safwan. Any question from the panelists, please?
Yes, if I can ask Dr. Safwan.
Please. Yes, please, go.
As I hear from Dr. Sandeep, it is difficult to treat cases of high-order aberrations with a smile. So shall we have a Schwind machine to correct these, or we have any other rules, for example, aberrometers to correct these high-order aberration with a smile?
So
my question for Dr. Safwan and also Sandeep.
Yeah, as Dr. Sandeep said, that for high-order aberrations should be excluded for time being. Now, there is a lot of improvement and there is a lot of studies, but still it's not in a trade. And hopefully that within 1 year or 2 years, we will have the improvement in current machine for smile from Schwind Tamars, that Atos, that can deal with the higher aberration. But for time being, no. And that remind me about one presentation in ISCARS when someone presents that there is an island, isolated islands in the center of the topography after smile. And when I asked him, did you check the higher aberrations for those patients before? He definitely not. So as Dr. Sandeep said, we need to exclude those patients. We need first to check them, select them, and then exclude them because they are not good candidate for a smile.
Dr. Safwan, I just want to add one piece of information. There is a promising results for smile in post-keratoplasty corneas. I think you have attended a few presentations for Dr. Osama Ibrahim, who has some good experience in that. It depends on correcting a considerable amount of stigmatism. So I think it might be promising in the future. It would not be that precise as the customized laser vision correction, but there is something on the way regarding this issue.
As I said,
but initially, during the initial workout for any refractive surgery, patients who are having high order aberration more than 0.5, I think it should not be a good candidate to go for a smile right now.
Exactly. Exactly.
So just one note. I've been doing correction of astigmatism with SMILE for last almost 6-7 years. The results are fantastic. I don't have any issues with them. Most of the patients do very well. They do suffer from glare for a time, but they all disappear in 6 months' time. The question of higher order aberration, one of the things which is good about SMILE is because you use a very high, you can use a very high optical zone, and there is no peripheral zone which is required. You can actually circumvent some of these problems of aberration by increasing the lenticular size. So that is one of the advantages. In coming to post-graft correction of astigmatism with SMILE, I have done 5 cases. The results are not bad, but they are not good. So if you are going to correct astigmatism by using SMILE, because the lenticular size is very tiny, you have to fit within the graft zone. Exactly. It's not easy. It is challenging, and I would not recommend. But yes, if somebody is very experienced, he can go ahead and do it. I think PRK or astigmatic keratectomy gives much better result in these patients. So that's in my hand. I may not be the best. There are many.
One question, Dr. Sandeep. What is the limit of the astigmatism number when you start doing the marking technique? For example, after more than -3, more than -4, what is your cut point? After that point, you start using the marking technique.
Yeah, it's a good question. I actually use marking for anything more than 2 diopters. So anything which is more than 2 diopters, I would mark. But the problem with marking technique initially is that you might have vacuum loss. So if you are going to mark these patients, you have to be a little bit careful, and you can go ahead and mark. But I think initially when I was not marking these patients, I started marking only about 3-4 years back. I didn't have any issues. If you do a soft docking first, and then your docking is good, you can just forget about marking. You still get good result. And I have done astigmatism up to 5 diopters with SMILE, and the results are not bad at all. So I don't know. It's a matter of controversy, here. But most of the literature, which has been there in the books, they say SMILE is not great correcting astigmatism more than 4 diopters, and there is always a residual undercorrection.
Sandeep, just one comment, if you don't mind. You said few things about the static torsional track system that will present in LENSAR, but I just need to add you that Atos will have soon. It's registered and it took the CE, and it will have the static registration, and we can with it enlarge the size of the lenticule, because the periphery of the lenticule is 0. It's not like in Zeiss that it's 3 micron. The periphery will be 0, and we will have 2 side incision, one for the passing to the above the lenticule, and one to below the lenticule. So there is a lot of advances, as you mentioned, and hopefully that we will go through, and we will have ability to treat the higher derivations, but the astigmatism will be up to 6.
Yeah, Dr. Do you mean there is an iris registration in this new machine?
Yeah, there will be an registration to the limbus and the iris.
Okay.
Yeah, Dr. Safwan, now regarding the side cut to be 0 has a disadvantage as well, because the dissection at the periphery may be difficult, and there might be some remnants of the lenticule. So this is why in the Visiomax, the least amount 3 microns, just for, let's say, very expert people, but it should be more than 5 microns. This is because we have many audience now attending, reducing the side cut.
That's the general opinion.
Sorry?
That's for general opinion, but when you apply it on a practical, and you will find that you will reduce the spherical abrasion by it, and it will be very easy to remove. So practically,
actually, this is not only my opinion. This is the expert's opinion as well.
That's right. That you are absolutely right, and that's what we totally different when we, for example, when we took the opinion of that expert that they said that it's not, and we need to make it more than 3 micron. We need to make it 5 micron, and then we let them to do the lenticular extraction in Atos. They found that it's much more easier when it will be 0.
Maybe then on that machine, the new machine, maybe
that the machine will be registered in
laser
UAE.
profile, maybe the laser profile and
exactly.
and the Atos,
you reach the
maybe
point.
it is something different.
Exactly, it is. You reach the point now. The laser profile is different.
Yeah, that's it. Okay, time will tell then.
Yes, it will be registered soon. It will be within 1 month. It will be registered in UAE. Hopefully that Erica will be in Russia. She will have it, and we will see.
Okay, great.
Unfortunately,
now,
Russia is not the first land for it.
Okay, any questions to Dr. Eileen?
Yeah.
Any questions to Dr. Eileen presentation?
Yes, for Dr. Eileen, what is her experience in correction of corneal dystrophies, for example, a granular?
Unfortunately, the net is not good with Najah.
Najah, we lost.
Okay, I will repeat my question. What is her experience about using BTK in treatment of corneal stromal dystrophy, for example, a granular? Still, my voice?
Yeah, we got the question. Dr. Eileen, you got the question, Dr. Eileen?
I don't think so that she's still with us.
No, she is with us. Dr. Eileen, can you hear us?
Yes, I hear. I think he asked me in
corneal dystrophies. How do you treat?
Especially granular dystrophies. I haven't my real experience. Sorry about that. Because of that, I don't talk about that. Okay.
Okay, great. Thank you very much, Dr. Eileen.
One more question, Dr. Eileen. In these cases, do you do corneal epithelial mapping to decide this irregularity is more in the epithelial level or in the corneal level? And do you do BTK in regularly irregular stigmatism or irregularly irregular stigmatism? I hope you got my questions. Actually, it's 2 questions.
I couldn't hear your voice. My connection is very bad.
Do you do corneal epithelial mapping in these cases?
Epithelial mapping in these cases?
Yes.
Yes. No. In this second case. In the second case?
In all of your
sometimes.
In all of your irregular cornea post-trauma, do you do corneal epithelial mapping?
So, we don't do in these patients.
Okay, thank you.
Okay, so we are on time now. So let's go to the second part of the session. We will invite Dr. Mohammed Husni to give his talk, Refractive Surgery Post-Corneal Graft. Please, Dr. Mohammed Husni.
Assalamu alaikum. Good afternoon, everyone. It is a pleasure and an honor to participate in any event that has Mazen Sinjab as a participant.
Thank you very much, Doctor.
It's also a pleasure. Thank you. It is also a pleasure to see and hear my friends, Safwan, Dr. Mehmet Badawi. We haven't heard him, but I've seen him just a couple of times. And on the camera, I mean, Mehmet is a good friend. And Dr. Alilo, of course, and Dr. Amri. So I'm really honored and pleased. I'm taking you guys on a different journey. I'm starting you on a totally different short journey, I hope. Just to tell you how, in our hospital, how do we tackle post-PKP astigmatism. In order to do this, I'm just breaking the ice with this very fast case presentation. These are the references, and these are the intended learning objectives of this presentation. And post-PKP usually ends up with corneal astigmatism. We all do that. Back where I come from and where I practice, we do a lot of penetrating keratoplasty. I do a heavy load of femtosecond penetrating keratoplasty in patients that are not suitable for lamellar keratoplasty in all of its techniques. But again, after 1 year of surgery, the usual corneal astigmatism ranges from 1 to 5 diopters, depending on the suturing technique and the post-operative course. Some things are within our hands, some things are not within our hands. The amount of inflammation that the sutures can produce, if the patient suffers from 1 or more bouts of rejection, you end up with tightening and fibrosis in one part of the wound, and you end up with astigmatism. Femtosecond PKP has dramatically reduced the amount of post-operative cylinder due to the innovative wound designs, less suturing, and the smoother post-operative course. But we have many weapons to tackle these patients, the post-operative astigmatic patients after penetrating keratoplasty. You have just mentioned one of them. Ahmed Alilu just mentioned the Dr. Osama Brahim's presentations on SMILE for post-PKP astigmatism, which is very, very innovative and very promising, actually. In my hands, we use either femtosecond arcuate incisions or excimer ablation of a sort. So this is a presentation of a case. This was a 41-year-old male who underwent penetrating keratoplasty in December 2014 for advanced keratoconus. Surgery was uneventful. It was a mushroom design, 8.7, 7.4 for the donor, and 8.6, 7.3 for the recipient. He had a smooth recovery. He traveled after 2 months, and he had his medications with him. He showed up after 5 months with an attack of allograft rejection, with a co-deduced line from 12 to 3 o'clock and accompanying suture-related inflammation in the same quadrant. So he had the inflammation and the rejection signs in only one quadrant of his transplanted cornea. Rejection was treated with topical and systemic steroids under cover with topical antibiotics for any bacterial suture-related infections. The patient responded very, very well, and signs of both rejection and infection disappeared. The area of treated inflammation showed moderate scarring, of course, and this was expected. He was followed up regularly every month over the next 6 months with a quiet eye and a best corrected visual acuity of 0.7 or 6.9. But unfortunately, this best corrected visual acuity was very artificial. He only could see that with 10 diopters of cylinder and in the clinic only. Of course, we couldn't prescribe 10 diopters of cylinder in his glasses, so we never saw the 0.7 that he used to see in my office. The patient was intolerant to hard contact lenses and to spectacle correction. He did not wear both, either the spectacle or the hard contact lenses. So in February 2016, he presented to our office seeking a solution. He had an upcoming job interview actually in the Emirates in Dubai. So this was his Scheimpflug image. This was his pentacam. And as you can see over here, guys, there's the area that had the rejection and which suffered from fibrosis post-operatively. And there's a great steepening in this part. And the astigmatism with the Scheimpflug was in the neighborhood of 8 to 9 diopters. With the topolizer, which is a Placido disc topographer, again, this part showed a lot of fibrosis and steepening, and he showed an anterior corneal astigmatism of 8.5 diopters. So we decided to go for arcuate incisions on the femtosecond machine, on the Alcon femtosecond machine, but which nomogram to use? Most of astigmatic keratotomy nomograms nowadays are aimed for limb relaxing incisions in cataract surgery. So he used a combination of Magee-Bozar and other femtosecond laser machine, namely the Intralaser nomogram for a 7mm optical zone. We believe that the topo treatment overlay on the FS200 was very, very useful. And this is very nice when you have the topography on the screen of your femtosecond machine. So it can actually move the arcuate incisions to match exactly the area of steepening on the cornea. But the bad thing is that this machine doesn't have a cyclotorsion compensation. Actually, you can do the docking and move the eye a little bit, and then you're totally off axis, and you can treat, well, not totally off axis, but again, you can treat an area which does not need treatment, and the arcuate incision does not match exactly the area of steepening and fibrosis that is present in the cornea. So this was the plan. This was the patient. Again, it was the percentage, the depth was 70% needed. And the offset, we used a closed system. We did not open up to the surface. We read a lot about the efficacy of femtosecond arcuate incisions, intrastromal femtosecond arcuate incisions. So we did this. And man, this was the treatment. And this was the result immediately after the treatment. And this, and immediately, by immediately, I mean immediately. After we did the arcuate incisions, we sent the patient down to do another topography immediately. We only actually lost or benefited from 2 diopter of cylinder treatment. So he was 8.5, he ended up with 6.7. So only 2 diopters of cylinder were corrected. So what do we do now? Should we open the incisions? And again, everyone was saying that opening the incisions to the surface is a little bit risky, especially in patients. This is not a virgin cornea. This is not native astigmatism. This is post-operative keratoplasty. Again, he had a bout of rejection. So these eyes are marinated in corticosteroids. So they have very low immunity. You can end up with infection from the depth of this arcuate incision. Or should we leave it for a few days to reach its maximum effect? What we did actually was opening the incision immediately. We sent him back up to the operating room and we opened the incisions to the surface. And what we ended up was, again, an augmentation of the treatment of 1 diopter. So we lost 3 diopters of topographic cylinder, 4 diopters in the manifest cylinder. The refraction of the patient became -6 cylinder, with the best corrected visual acuity this time of 1.2. So he really, really saw well. He felt the improvement, but he, and honestly me, wanted more correction. So we decided to do a second step. So we decided to tackle the corneal astigmatism with the other weapon, namely the excimer laser. The first decision that we had to make, that had to be made, should we use obviously topography guided ablation, or shall we use wavefront optimized, especially that the best corrected visual acuity was 1.2. So actually with this manifest refraction, the patient could see very, very well. And we do not want any fancy ablation in this cornea that has a track record of having a mind of its own. So the second decision that had to be made at the time also, in a patient with a PKP complex scar. Again, these are not manual penetrating keratoplasty. These are mushroom keratoplasty with complicated architecture and a wide zone of fibrosis and scarring. 2 arcuate incisions, we do a surface ablation, or should we do a LASIK? Okay, we didn't have the option of a smile at the time. I wouldn't do a smile for these patients up till now. So we had, so these were the options. Shall we do a wavefront optimized plus a surface ablation, or wavefront optimized with a mechanical microkeratome LASIK, wavefront optimized with a femto LASIK, or shall we do topography guided ablation, again, surface ablation or mechanical microkeratome or femto? I would have chosen a topography guided ablation with the surface ablation, but the patient was due to travel in 10 days. And again, we know the post-operative results of the PRK, especially in a patient that had a corneal graft and a previous graft rejection, can be a little bit stormy and can take a longer time. He wanted a faster visual rehab. So I decided to do a TCAT with a femto LASIK. And this was the plan. Again, it was a nasal hinge just to get away from all the axis of ablation with the excimer laser. And everything went absolutely fantastic. The patient started off with a 5.7 diopters of astigmatism, ended after the LASIK with a 2.4 diopter of astigmatism. 1 week post-operatively, the astigmatism was 2.16. So the patient was really happy. I was happy as well. The uncorrected visual acuity in this patient was 6.9. And with a -1.75 cylinder, he saw 1.2. Patient was satisfied, and so was I. But he developed the habit of coming back to me and wanting more. So he asked me if I would recommend further corrective procedure. The options at the time was to counsel the patient, advise him to wear his spectacle correction for the remaining cylinder and not to consider any more procedures, or to go ahead and schedule the patient for an evaluation in the next annual vacation to do another excimer laser ablation. But this was my opinion. This is what I told him, that he should just have to stick to his spectacles, and he is very happy up to this very, very moment. So just a quick recap about this patient. He started off with 8.5 diopters of astigmatism. We did intrastromal arcuate incisions, femto incisions. He was 6.7 diopters of astigmatism. After that, he went down to 5 diopters of astigmatism. And then he ended up with 2 diopters of astigmatism topographically and 1.75 in the manifest refraction. So what the heck is post-PKP arcuate incisions? What's the deal with it? What are the nomograms? Classically done freehand or with a mechanized device, such as the Hanna archetome. Old techniques have very poor predictability. And the thing is that a lot of nomograms for this specific condition were developed after like 10 cases or 12 cases, not with a true regression of hundreds of patients. For example, a very, very famous nomogram that used to be used for years was the Lindstorm nomogram. And Lindstorm himself said that it was developed after 10 cases. So people used to use the Lindstorm and the Hanna nomogram, but this was for the native astigmatism, and they were freehand. Abbey in 2009 developed a nomogram for femtosecond AK based on Lindstorm, but again for native astigmatism, not for post-PK. And Humeric and Wu in 2010 developed the first femtosecond AK nomogram. The Hanna nomogram is a very new one. And the McGee and Buzar have shown that arcuate incision should follow the steep portion of the scarred corneal host or the steepening. So this is very easy, and it's not really a nomogram. The Toronto University nomogram is very, very nice. It's very handy and very easy to use. It's 60 degrees pair for 6 diopters, 70 degrees for 7 diopters, 80 degrees for 8 diopters, and so forth. And the most recent nomogram is the one developed by Claire, and they actually invented a new measure or a new parameter called the incision magnitude. And it's in a very famous landmark publication, Journal of Cataract Refractive Surgery. I think it was in 2018. And this is the nomogram that Claire used with the incision magnitude parameter. And that's about it. So I thank you so much for this opportunity to join the heavyweights in this refractive session. Thank you.
Now you're going to hear me, Dr. Muhammad.
Thank you, Dr. Mohammed Husni. Thank you for being on time. And then we will finalize with the last presentation, Dr. Erika, Presbymax hybrid for correction of presbyopia. Dr. Erika, the microphone is with you. Thank you.
Yes, thank you very much to inviting me to this nice and famous meeting. Let me try to demonstrate the screen. Is it visible now in full screen mode?
Yes, it is.
Okay, excellent.
It is not in full screen. We can see your screen.
Not full screen. Okay, I will now improve it and make a show better. And again, my presentation today is devoted to my experience of Presbymax. And we have a 4 years follow-up time. I think it's a nice experience because one of the important key points to present the data of correcting presbyopia is to show how stable is the result. So I'm just fighting with the screen, trying to show the full one. Just a second. I think this time it will go on. Now I think I am successful,
yeah.
Yes?
Yeah,
oh,
great.
Okay,
Thank
good.
you.
So, and I would like to confirm that I have no financial interests related to this presentation. Here is my references, which I was using to prepare this presentation. And as an objective, of course, you all know that presbyopia is a common condition, and still there are different approaches preferred by different surgeons, some of them intraocular, but we are talking today about the corneal approaches. If we're talking about the presbyopic population, we all know that the population is becoming older, and it means that the amount of the patients with presbyopia is increasing, especially in Western Europe and in Japan. And I was trying to find the data connected to the Middle East countries, and here we can see a relatively new publication where the amount of patients with presbyopia is mentioned in millions, is in absolute numbers. And we see that in the Middle East, it's a lot of patients who still requiring a correction of presbyopia, approximately 50% of the existing presbyopic patients. If we're talking about the patients with presbyopia, we can separate them into 3 groups. And one is with cataract, and it's not interesting for us for the corneal approach. The second is 55 plus, and I think even they have a clear lens, it's not fair to perform the treatment on cornea, as well as the lens is not accommodating anymore. And in the age 45 to 54, we still have movement of the lens, and we have patients with different types of the refraction. And I think this is our target group we are talking about. So there are different popular corneal approaches existing now at the market. There are a lot of them, but most popular are mentioned here. And if we are talking about presbyopia correction, we should mention special requirements which are a little bit different to the requirements in refractive surgery. So we are talking about not only distance vision acuity, but we are talking about the near vision acuity. And the requirements to the distance vision acuity uncorrected after the surgery are a little bit lower than in a normal refractive surgery. The safety requirements are also a little bit softer. So we are talking about 2 lines, losing 2 lines, not more than 2 lines in BCVA. The predictability of the treatment and planning is also a little bit more difficult in these cases, and we are talking about half a diopter precisement in these cases. And the most important is the retreatment rate. So how long is the duration of the effect of presbyopia treatment? And the amount of the patients who are not accepting the treatment which we offer them, so they require for a reversal treatment. You see here the comparison with different methods, and I'm going to talk now about the Presbymax hybrid approach. Presbymax is an approach which is offered by Schwind Eye Tech Solutions, and it's make a multifocal biospherical profile on the cornea, and the near is in the central area of the cornea, and the in periphery is the far area. It's also exists in the intermediate zone and transition zone. The refractive diapason is very large for these patients. We can offer presbyopia treatment for myopic and hyperopic patients and the patients with astigmatism. And if we are talking about Presbymax, we have to know that the effect is based on biospheric multifocal profile, forming slight micromonovision and slight anisometropia. It's based also on the pupil mobility during the accommodation, creating the negative spherical aberration, and this profile is pupil dependent. Here you can see the light distribution concept of this approach and the requirements to the pupil size in photopic and mesopic conditions. Looking at the profile, we can separate this approach to the dominant eye and to the near eye. Dominant eye is always focused on the distance, and we see that the target in case of addition 2,25 diopter, target for near is low myopia. And in the near eye, we see that target for near is minus 2,14. And for intermediate distance is 0,9 diopter. So the depth of focus for the near and for the distance is a little bit different. We see difference for distance 0.75 diopters and for near 1,5. It means that the recovery for the distance vision in this approach is a little bit faster. And we see that all the distances are covered with such an approach. I would like to present the results of the treatment of the 50 patients, 100 eyes with different types of the refraction with myopia and hyperopia. The observation time was up to 48 months, and we tested standard parameters connected to presbyopia treatment. So normally the diagnostics in refractive surgery is limited by standard test, but in case of presbyopia treatment, we tested additionally, of course, the dominant eye, the vision acuity in different distances, binocular and monocular. And we also made a trial test with multifocal soft contact lenses to be aware that patient accept our treatment. So I compare my data with multi-center data, and you see that the treatment is in multi-center data is very precise. 96% of the patients are within half a diopter from ametropic target on the distant side, and near eye is a little bit less precise because of the multifocality of the cornea, and it's 82% of the patient are within 0.63 diopter from the target. You see the distribution of the predictability in my study. It's also visible that it's a little bit under correction. And if we are talking about the main parameter, near vision acuity, after the surgery, we see that in hyperopia cases, it's stable within the observation time, and we see the vision acuity 0.6, 0.65. And for myopic patients, it's up to 0.74. So it's more than enough to cover the task for the near distance. And normally we are testing again binocular vision acuity, and we are always saying patient that he should not compare the eyes and should watch with both. And you see that binocular near vision acuity is stable and stays at about 0.8 in decimal units. Distance vision acuity we test normally in the dominant eye, so it's more important, of course, and more predictable. In hyperopia group, it was 0.93 during the end of the observation time, and in myopic cases 0.94, 0.9. And binocular vision acuity in these groups were also stable and at about 1.0. Safety was also good in our study, and you see that corrected distance vision acuity, this dark blue column, 92% of the patients didn't change best vision acuity, and only 1% lost 2 lines and no one more in best corrected vision acuity. It's also very important in this group of patients is expectation management, and you see that we have to talk to the patient and explain them that uncorrected vision acuity will be 1 or 2 lines worse than BCVA preoperatively, and that it will be a little bit diminished image postoperatively, and that they will feel gallo a few weeks after the surgery, and they need time for neuroadaptation. It's also clear that it's a pupil-dependent profile, and in case of the bright light, they need sunglasses outdoors, and in case of the long distance driving, they probably could need low spectacles. As a conclusion, mean binocular functional outcomes are very good in Presbyopia breed, and it's predictable enough, especially in dominant eye. Near vision acuity recovers faster than distance vision acuity, and we can expect a stable near vision acuity first day post-op, distance vision acuity 2-4 weeks post-op, and the maximum we reach at 3 months post-op. It's safe. 99% of the patients are within ±1 line from BCVA, and change in spherical aberration, of course, is more significant for the near eye. And we recommend an individual approach to the patient, precise preoperative diagnostics, choosing the best fitting approach for the patient, effective collaboration with the patient during diagnostic and in post-op period especially, and constant support of the patient during all the period of the time of vision recovery. So thank you for your kind attention.
Thank you, Dr. Erika, for the nice presentation and for being on time. Actually, we are on time and we still have around 8 minutes for discussion. So if any question from the panelists to Dr. Erika presentation or Dr. Mohammed Husni presentation. Let's start with Dr. Mohammed Husni presentation. Any question from the panelists, please?
Sinjar?
Yes, doctor, go on.
Yes, for Dr. Mohammed. Please, Dr. Mohammed, one of the important points in, for example, adequate keratectomy or any refractive surgery is a stabilization of refraction. So what do you think the proper time to do such procedure in patients after penetrating keratoplasty? And we should remove the stitches, or before that we can do this procedure?
We should remove what?
Stitches. The stitches.
Of course. Now, in the world of femtosecond PKs, I remove the sutures after 6 months in most of the patients. Some people actually remove the sutures after 3 months, not 6 months. Now, I do not recommend any type of refractive surgery for treatment of postoperative astigmatism or sphere before 1.5 years, 18 months from the operation, from the primary operation. Again, this can be delayed a little bit if the patient suffers from more than one bout of rejection, and we bombard the rejection with all our weapons. And if the patient is good, we actually wait, because the element of fibrosis and the fibrotic process does not end in a month or two, and you can end up with astigmatism, which is totally different than the astigmatism that the patient has immediately after the treatment of the rejection. So I would stay put, hold the horses for another 6 months, and then work on something which is stable, on a refraction which is stable, rather than doing something early and then ending up with more cylinder.
Thank you, Dr. Mohammed, for Dr. Husni for
أخيراً Dr. Alilu.
the fantastic result. I just have one question. How about the thickness of your LASIK flap and the thickness of your arcuate incision? Because when you do a flap in a deep incision, you might risking that this flap might get cut, or you have this pizza effect or something like that.
Sorry,
do you remember?
Come again. If you have, I didn't find any problem doing a flap in these patients, except for the very simple thing that you really need to do the flap inside the graft, because these patients have a wide zone. Now, we have done actually an MD thesis. This was a case presentation, but we have done an MD thesis with 23 cases, and it is under publication right now. It is under review. The thing is, they have a very wide zone of healing if you're doing a top hat or a mushroom. So if you're going to do a femto LASIK flap, I would definitely recommend, if you're doing a lamellar procedure, to do a femto LASIK flap, not a mechanical microkeratome. For the simple reason is that a mechanical microkeratome, it's much easier. But again, you will have a thicker flap. It cuts everything. I think you lose what you actually have gained from doing a penetrating keratoplasty in the terms of corneal biomechanics. The mechanical microkeratome disrupts everything. The cornea becomes, again, and this is a transplanted cornea, becomes again weak. So you are actually exposing the patient again to the keratoconic process that you perform the procedure from the start because of. So in these patients, I do a small flap inside the donor cornea, and I didn't find any problem. Actually, part of the flap was overlying the arcuate incision, and when we elevated the flap, you find that the flap is like cut in the areas of the arcuate incision, which is not a big deal at all. You do the ablation and then put the flap back in place. I don't think this does affect the results.
I think the beauty of the femto LASIK here is the precise planning.
and the precise results you have, because you can plan your flap deep enough to have enough stromal support below your arcuate incision. Thank you again for your answer, Dr. Husni.
Dr. Mohammed
Hope to see you
Husni,
soon
there is
live.
a question. There is a question from one of the audience. How much did you wait for the LASIK after the femtosecond AK?
Okay, now not in this specific patient. This specific patient had a lot of things going on in his life, and he was traveling and he had interviews and stuff like that. But in the 23 eyes series that is under publication now, we do the arcuate incisions and then we wait for 6 months and then do the excimer laser ablation of any sort.
Great. Another question. What about doing compression suture in your case if the effect of the AK is less than expected?
Compression sutures in these cases in specific, you cannot apply them. They're not applicable for a very simple reason that in these patients you have extra fibrosis in a part of the line of healing. In this extra fibrosis, you have extra steepening in this part. It doesn't make sense to do an extra steepening in the opposite meridian. It makes more sense is that to relieve this fibrosis, to relieve the pull, relieve the steepening in this area, and you end up with very sort of natural results. In order to do a wedge resection or compression sutures in the opposite of the 90 degrees perpendicular meridian, I think you'll end up with irregular astigmatism in these patients.
Thank you. Any other questions?
Can I ask a question now?
Dr. Imad Badawi, yes, please.
Dr. Mazen? Sorry.
Hello, Dr. Muhammad, how are you? So which nomogram you use right now for astigmatic keratotomy post-PKP?
I use a combination. The straight answer is the Toronto University nomogram. It's very, very easy and very, very handy to apply. But actually, we've been putting on the Claire nomogram as well. And some patients we use this, some patients we use that. Again, we don't have a large, series to do a regression formula and to see which one works better. But both of them, they do very, very well. At the end of the day, these are not refractive surgery cases that you want the patient to end up seeing 6/6 with no help at all. In this example, this is a very, very classic example of our patients. Yeah, he ends up with 1.5 diopters of astigmatism, 2 diopters of astigmatism, 2.5 diopters of astigmatism with the glasses C6/6. He's happy, over the moon. We're happy, and I think this is the satisfactory results in these cases.
Dr. Mohammed Husni, just one comment if you don't mind.
All the time, or you just do it intrastromal? I mean, you open all the way.
I have abandoned the intrastromal arcuates since the first few cases. I always do them up to the surface.
Yeah, that's what I do.
Dr. Mohammed, if you don't mind, Mohammed Husni, the issue is that you are using the Toronto nomogram, but you didn't tell us about what the depth of your arcuate. And you used 2 different sizes, one of them on one side and the other on the other side. And I do agree that the track system, static track system, is very essential here to put the arcuate on the steep axis. But tell us what's the depth and why we use different sizes.
Actually, I commented on these 2 comments, Safwan.
Yeah.
You're not paying attention, Dr. Safwan.
No. I'm paying attention in details for you.
Okay. No, the thing is, since we were using the Charles McGee-Boussard nomogram, it actually says that you have to do the incisions all through the area of steepening. So this means that you cannot end up, Dr. Safwan, with exactly the same arc length of both incisions on both sides. So this is what we use. We use the combined nomogram in this specific patient. And again, for the depth, I mentioned this in the presentation, I always go in these specific patients for a 70% depth. I don't go for an 80% depth. I definitely don't go more than 80% because these patients have very complex fibrosis going on. And honestly, as Safwan, the thing that I'm really worried about in these patients is that these incisions might gape. And if they gape, they can invite infection, and it will go into a very, very dark road from that. We need to get away with as minimum as possible for the patient to be satisfied.
Thank you, Dr. Mohammed Hosni. And yeah, one more question, and we have to stop because we have a buyer session, please. So only one question.
Just one question. What's the optical zone for this arc weight? You are on 9 or on 6 or 7? 7. Yeah.
Very good. Any question to Dr. Erika presentation?
One question to Dr. Erika. Any information in the study regarding what will happen for those patients when they had cataract? And is it possible to have premium IOLs or not?
We have only recommendations from the manufacturer, from Schwind, that if we use a normal aspheric monofocal IOL in these patients, we will keep the multifocality and keep the possibility to read without glasses. It's strictly not recommended to use premium multifocal IOLs. I think the key point is the precise calculation of the target refraction in these cases. And we so far have a few cases only experience from our side, and they are successful.
Okay, thank you very much, everybody. On behalf of the co-moderators and on behalf of myself, I'd like to thank all the speakers for their very nice presentations. We learned a lot from them. And now I would like to leave the microphone to Bayer team to give the presentation, to start their symposium. And I would like to invite the audience and the participants and the speakers to stay with us, please, for the Bayer symposium. Although we are anterior segment, but we may get benefit from retinal surgeon. We may.
I'm sure you will. I'm sure you will.
Thank you.
You need a functioning retina in order for your patients to see very well after your fantastic refractive surgery.
Sure.
My name is Avi Gurbaksani, and I will be presenting on part of the Bayer symposium. I am a consultant ophthalmologist, medical retina and uveitis specialist, and chief of retina service at Moorfields Eye Hospital in the UAE. And my topic today is to discuss the journey, actually, that we've had with aflibercept over the last several years. So, retinal disease is really very prevalent and perhaps growing as our population is either getting more and more diabetic, 28 million people with diabetes, people with hypertension and obesity. They tend to develop retinal vein occlusions, 28 million there. And as our population is growing older, as all of us are, AMD becomes also very relevant. And I always say, as a medical retina specialist, if you have a very bad quality food, you're indisciplined, you don't exercise, you put on weight, then you will develop diabetes, and you need a medical retina specialist. If you are very healthy, exercise, eat well, then you will live very long, and then you will develop AMD, and so you cannot escape seeing me, if not now, then in 20 odd years' time. The clinical road to success, the field of retina has changed so dramatically over the last 15 years, 20 years. I can't even believe that Visudyne was approved for AMD, because it worked so rarely. But then when there was no treatment, Visudyne was seen as a great hope. Around that time, the VEGF trap investigation for AMD was filed. So that's 17 years ago. And the first anti-VEGF, Macugen, was approved in 2004. So that's, you know, quite a long time back. And this was with Robin Geimer and his team in the US. Avastin then came into clinical use in 2005 and is still used. Lucentis in 2006. All this while, the treatment with VEGF trap was under investigation, and all the pivotal trials, View 1, View 2, etc., came to fruition. And then finally, in 2012, EYLEA got approval. So my first experience with EYLEA was around 2013, or 13-14, and that was in Australia when I was doing my fellowship. And then when EYLEA was launched in the Middle East, I believe I was the first person to use it in all of the Gulf. So as of September 2012, so 8 years ago, aflibercept has been approved in Europe for the treatment of neovascular AMD. And it still remains the gold standard of treatment. You know, it has shown that the approval journey, we've seen that proactive Q8 dosing was the initial hallmark that, you know, differentiated this drug compared to the other drugs in the market. And this showed a strong efficacy, and that then led to the treat and extend posology in year 2. Similar things were found in vein occlusion and diabetes, myopic CNV, and BRVO as well, where you could have a proactive dosing strategy. So aflibercept has now become, as I said, the gold standard of treatment for several retinal diseases. In AMD, it's approved in 109 countries. In DME, 104 countries with the weight of these clinical trials. Retinal vein occlusion in 106 for CRVO and 103 for BRVO, and for myopic CNV in 99 countries. So, you know, 5 indications have been added in the last 3 years. There are about 4.5, nearly 5 million patient years exposure, and more than 33 million vials have been distributed since the launch. And I believe that, you know, aflibercept or EYLEA is, for ophthalmology, it is actually the world's 2nd largest selling drug. The number 1 being Humira still, number 2 is aflibercept. So really it is very versatile and used in so many different indications in so many countries with great success. I mentioned the treat and extend, you know, and that's perhaps the new information. We won't talk about the licensing studies, etc. Everybody knows that. But the important thing is with the use of EYLEA, you know, in the Altair study, at the end of 2 years, 60% of the patients were extended to injection intervals of 12 weeks, and 40% reach intervals of 16 weeks. So that really makes a big difference. Remember, these patients will need injections for years and years. And so in order to reduce that treatment burden, certainly we've been looking for injections that are needed less frequently, and all the trials will be all the new drugs also are trying to find that you know, less frequent dosing interval. It really reduces the burden on the patient. It reduces the burden on the clinical practices. But Altair, you know, demonstrated that with EYLEA, which is already the gold standard in the market, 60% were extended up to 12 weeks, and 40% reached intervals of 16 weeks for maintenance of their age-related macular degeneration. And you can see that the proportion of patients here totally extended were 48% for 16 weeks with a 4-week adjustment for 77%, and with a 2-week adjustment, 96%. So really, it's, you can also transfer this confidence to the patient that, there is a high chance that we will be able to extend you and maintain you on the treat and extend regimen once you have stabilized. So yes, all patients will need a loading dose, and yes, some patients will need monthly injections, some 6 weekly, some 2 monthly. But we can explain this to the patients that, as an individual, we can tailor the treatment to your eye, and that you have a 40 to 60% chance of needing an injection every 3 or 4 months. So that really gives the patient some confidence and something to look forward to when they begin their treatment journey with Eylea. This patient of mine, she has been coming to me for last 5 years on a treat and extend, and now she's on Q16 to both eyes, and her retina looks pretty good in both eyes, and she's been getting injections for the last 5 years. Initially, she had monthly injections, and then we switched her to 2 monthly, 3 monthly, and now she's on Q16. So here she is in 2015, which is the top left picture. The same patient a year later, again, looks pretty good. On the top right, that's the same patient in 2018. And, this is the same patient in 2020. So over 5 years, the wet AMD has reduced. Of course, she's developing a little bit of atrophy, which is the natural history of the disease, because, we are converting this wet macular degeneration back into dry macular degeneration. But her vision is still very good. She's about 6'9", 6'12" in this eye and in her other eye, and she's very satisfied. So this lady also, you can see the other eye. Here she's again in 2015 when she first started out. Again, 2017 looks pretty stable. Here's this lesion appearing with a little bit of atrophy over there. This is in 2019. And then at the last visit, again on Q16 treatment. So now she comes in every 16 weeks, has her injection, and feels pretty stable and satisfied that her vision is under control. 6'9" in each eye. Now, moving on to diabetes, Protocol T, of course, we've all heard at length about Protocol T, but a post hoc analysis was done of the Protocol T, which demonstrated that the vision that aflibercept led to superior vision gains over 2 years compared with ranibizumab or bevacizumab in patients with a baseline vision of less than 69 letters. So patients with vision worse than 20/40 did substantially better with Eylea, and you can see they get better early, and that huge difference at year 1. And although that difference is bridged to some extent by Lucentis, there still remains a 2-letter gain. And if you look at the area under the curve, you can see that there's a big separation between Eylea and the other anti-VEGF. So you can see the area under the curve is 17.1 for aflibercept, 13.6 for ranibizumab, and just 12.1 for bevacizumab. So EURETINA guidelines now say that aflibercept is the drug of choice in DME with a baseline vision below 69 letters. And that is from the outcome of the Protocol T. And in the Asian guidelines, choice of anti-VEGF depends on baseline vision. And in patients worse than 612, aflibercept may result in a more rapid vision improvement than ranibizumab over 1 year. And this, although this, as I said, was not statistically significant at year 2, it still is significant. Now, let's look at a case. So this gentleman is poorly controlled type 2 diabetes. This is a policeman who is in charge of all of our lives and safety. And he said, I kept crashing the police car, which was not really helpful, considering that he's the one responsible for our safety. And you can see the reason why he kept crashing the police car. He's got this very bad proliferative diabetic retinopathy with extensive maculopathy. And you can see these ghost vessels here. So you can imagine he has a lot of ischemia. So we did here's his fluorescein. And that shows severe capillary non-perfusion here in the right eye and the left eye, large areas of non-perfusion, neovascularization, and of course, if I show you his OCT, you won't have to guess how bad it will look. So gross diabetic macular edema, but optimistically, the outer retina still looks reasonably good. So this gentleman, of course, had some PRP laser, and but I quite rapidly started him on Eylea, and initially on a monthly dose. And you can see how quickly, in just 3 months' time, his macula has restored back to normal. He's back to 612. He's back at work, not crashing the police car, and keeping us all safe. And so this guy we extended, and then he now gets every 3 months an injection. His PRP I completed over several weeks, and he's much more stable now. So such a severe amount of VEGF drive suppressed quite rapidly by Eylea, showing that these patients with poor vision, remember he was 660 at the outset, do very well, as evidenced by the protocol T. And you can see the proof here that he's improved so well. Now moving on to RVO. So the LEVO study, which was a randomized head-to-head non-inferiority trial comparing the 3 anti-VEGF available at the time, aflibercept, ranibizumab, and bevacizumab. This was done in the UK and headed by Phil Hyken at Moorfields in London. And these patients were randomized 1:1:1 to have either of the 3 drugs. And they wanted to see the primary endpoint being the change in the vision to week 12, also looking at the central subfield thickness and number of injections. So here you can see that the mean change in the vision was the highest for the aflibercept group, 3 letters more, 2.5 to 3 letters more than the ranibizumab group, and more than 5 letters compared to the bevacizumab group. And the number of injections with the ranibizumab were nearly 12, with aflibercept were about 10, and again with bevacizumab was about 12. So when you do the intergroup comparison, aflibercept and ranibizumab kind of did similar, although there were more injections in the ranibizumab group. But bevacizumab, failed when compared to aflibercept at both the week 52 and at week 100. Bevacizumab was sort of kind of similar to ranibizumab at week 52, but not at the primary endpoint. So you can see that this is a very nicely conducted head-to-head study, really, matching these patients, matching the treatment, and then getting us this sort of high-level data from the LEVO study. And so looking at this case, this 45-year-old lawyer, he had retinal vein occlusion and was diagnosed and treated elsewhere about a year before he came to see me. And he was started on another anti-VEGF and also had some pan-retinal photocoagulation, but it really wasn't controlled. So you can see, this is when I first saw him. He'd already had a good amount of PRP, you can see, but he still has this macular edema, and it kept recurring no matter what. So this is the macular edema, and he was sustained on anti-VEGF, and unfortunately the macular edema didn't really disappear. However, when he was switched to Eylea, quite rapidly he had marked improvement on the OCT and also his vision. And fortunately for him, his vision was still very good. It was 6.6, and after the injection, and he was very pleased. So even in these patients where they've had previous treatment, really, if you shouldn't be surprised by this result when you have read the results of the LEVO study.
Dr. Avi,
yeah,
we have 3 minutes from now, please.
Yeah. Okay. Yeah. So I'm nearly finishing. So the as we said that aflibercept is already licensed in several indications, but also there is a study to get it licensed for neovascular glaucoma, recently approved in Japan, but hopefully it will be approved in other countries. And for ROP, the Firefly study is also going on. Hopefully it will be approved for that. For diabetic retinopathy at the moment, it is licensed in the United States of America. Real world evidence, there's plenty of real world evidence. Many of the people on this symposium of listening in, attending this conference will be in the Auriga study. More than 5,000 patients are included. But you can see all over the world, there are several studies going on looking at the real world evidence. This study from Marco Lucic in Moorfields in London, looking at DME patients, they found that patients, compared to baseline, they had the maximum gain of 11 letters in the poor vision patients. And with the number of injections at month 36, if you have poor vision or good vision, it is about the total cohort about 12 at month 36. So, so majority of the patients had received 5 initial monthly doses and then needed not very frequent injections over 3 years to maintain good vision. The FRB study also compared aflibercept and ranibizumab, and you can see that compared to, you can see that the vision gain 7.6 letters in the ranibizumab arm and 10.6 letters in the aflibercept arm. So FRB also here corroborating with the protocol T evidence that aflibercept seems to be more effective. And this patient, had macular edema, diabetic macular edema, treated with ranibizumab, pseudophakic patient, still had macular edema. So I treated him with steroid implant, but he did not improve. Then I said, okay, let's try Eylea, and lo and behold, he starts to improve. So, excellent there. Safety-wise, 33 million injections or 34 million injections of Eylea have been given, and the rate of intraocular inflammation remains very low at 0.012%. So that's 1.2 cases per 10,000 vials that have been sold. Rate of endophthalmitis, as we know, is extremely low, less than 1 in 10,000. And retinal vasculitis, it's been only 7 cases in the 34 million injections that have been given. So really 0.00002%. So, safety-wise, especially with the vasculitis and inflammation being topical at the moment, Eylea has shown great safety. So excellent experience of Eylea, I would say, over the last 5 to 6 years. It's versatile, it's reliable, it's effective in the refractory cases as well, as we saw. It's effective in 3 of the main diseases that we see: AMD, DME, RVO. Also soon to be licensed in neovascular glaucoma and ROP as well, I hope, in our country. So thank you very much for your patience and for listening to me. And thank you to Bayer for inviting me to present this symposium.
Thank you very much, Dr. Abi. It was very excellent presentation and covering most of the things in a very nice way. Maybe Dr. Mazen, you will finish easier now. Dr. Mazen.
Thank you.
Okay. Dr. Mazen, can you hear me? So you need to finalize.
Hello, everybody.
Yes.
Yeah, thank you, Dr. Avinash, for the very nice presentation. It was excellent. I'd like to ask the panelists if they have any questions.
Dr. Mazen, there is 2 questions in 1 minute if someone can answer.
Questions?
Yeah.
Yes.
Dr. Muhammad is here or not?
We already answered. These 2 questions already answered to Dr. Muhammad Husni.
Okay, thank you. We can conclude, please.
So thank you very much, everybody, for attending this session. Thank you, Dr. Mohammed Al-Amri, for your innovative idea of this MEOM, and which is a very nice opportunity for gathering such eminent speakers, and we are very delighted to have such a high number of participants in all sessions. And I'd like to thank all the speakers today with us, and thank you very much all, and goodbye. See you in the future, in the near future, inshallah, maybe physically.
Yeah, before we close, we are going to have the second session. It will be from 7:30, but we will open now for the participant to join us. We will have pediatric and glaucoma with very eminent speakers. We would like to invite all to be with us there. And thanks for all speakers and all panelists. Thanks a lot for you, Dr. Mazen, for your effort, Dr. Safwan, Dr. Najat, Dr. Avinash, Dr. Alika, Muhammad Husni, Imad Badawi, and everyone was with us. And thanks for all of you. And see you.
Thank you, Dr. Mohammed. Thank you.
Thanks,
Bye-bye.
Dr. Mohammed.
Thank you, Dr. Mohammed.